Hi, I'm Katie Quatman-Yates, and I'm going to be giving a presentation entitled Community-Centered Fall Intervention Team, we call it Community Fit for short, a systems science approach to fighting the wicked problem of falls. So I'd like to begin with a personal story about my dad, who was a lifelong educator and was diagnosed with glioblastoma in January of 2020. As part of his journey from time of diagnosis to his death in May of 2020, one of the things that he was really felt was really important to do before he died was to help educate others about fall risk prevention and work with us to help share his story so that we could help improve fall prevention for others in the future. And one of the specific stories about him was that during the first 2 weeks of the pandemic, we noticed a significant decline in his functional mobility to the point that he was mostly relegated to sort of living most of his days in a recliner chair with one of those remotes to help him get up out. And at one point, he got confused about the direction that the chair would go, and he tipped it up, and it kind of tipped him out to the floor. So he didn't quite fall, but he had definitely ended up in a position of immobility on the floor and couldn't get up. Even though I'm a physical therapist and was there with him at the time with three other able-bodied people, we were unable to get him off the floor. And we had the fortunate ability to spend the past couple of years working with fire and EMS groups on engaging in fall prevention and lift assist support systems. And so not having really any other options, we didn't want to call 911, but we were able to actually find a local neighbor who had a gas mask because we were right in the height of the pandemic and weren't really sure about disease transmission. And my dad was significantly immunocompromised, and he came in and brought some materials to help us get him up off the floor safely. And we were extremely grateful. And in reflection upon that, we know how extremely lucky we were to not have to call 911 and transport him to the hospital or other things that likely would have happened had we had to use the typical protocol for getting somebody up off the floor and somebody as sick as he was. And the rest of these photos represent some of the journey that we had with our dad in terms of leveraging our partnerships with the fire EMS units to help keep him home safely throughout the course of his care. So falls are a huge public health problem. Most people have someone they love or care for whose fall risk is so high, it's not a question of if, but when a serious fall-related injury will occur. In healthcare, in our daily lives, we are inundated by newspaper headlines and research studies highlighting this problem. In fact, a CDC report identifies unintentional falls as the #1 cause of non-fatal injury in the US for all ages, races, and sexes. So solving this problem is going to be extremely challenging as the rate of falls continue despite a robust set of evidence-based strategies, publicly available resources that are out there to help prevent falls. The reality is that individuals who are vulnerable to falls touch nearly every clinician in every sector of every healthcare profession, yet the fall rates continue to rise despite this availability of evidence-based strategies and publicly available resources. This suggests it's not simply a lack of evidence problem or a lack of resources problem, but one that is deeply rooted in a lack of personalization to vulnerable people's individual needs, as well as a number of care gaps in our healthcare system. The problem is complex. In other words, it's a wicked problem. So wicked problems are those types of problems where you find yourself saying, I don't have a solution, or the solution, well, it depends, or it varies, or we don't really know. These are high burden problems that are difficult to tame or seem impossible to solve. And the reality is most of our wicked problems, if not all of them, are actually reflective of what we would call complex systems. Complex systems are systems in which we have incomplete or contradictory knowledge that's out there. We have many overlapping stakeholders with different perspectives and opinions, and they have many interconnected factors, variables, agents that interact in dynamic and difficult to predict ways, oftentimes at multiple scales or in nested ways. So like a micro, meso, macro type of field where they're all these levels are kind of interacting with one another. So kind of go back to the personal story. This is a picture of my identical twin sister. Her name is Carmen Quatman. She's an orthopedic trauma surgeon. That's our first day of kindergarten. And we actually started as professors at Ohio State the first day together on September 1st in 2017. So that's a picture of us on our first day as faculty members at Ohio State. We actually have very complementary interests and expertise. And prior to joining Ohio State, my history in physical therapy and implementation work had primarily been with pediatric groups and also specifically in brain injury contexts. Well, Carmen was very interested in geriatric trauma and specifically how to prevent falls so that we actually have less morbidity and mortality going on with geriatric falls. And one of the things that she had done during her residency and fellowship prior to joining the faculty at Ohio State was start to work with a paramedic group out of Minnesota, where they were trying to look back historically on 10 years of EMS fall call data to help appreciate what was actually helping what was actually happening in our healthcare system relative to fall calls. And what they realized in looking back in 10 years worth of data was that, over time, the total number of fall calls were increasing. The number of lift assists, which would be something like where it wasn't actually maybe a fall, but something more like what happened with my dad, where there's the person ends up on the floor, but there's not really any injury associated with it. So fall calls going up, lift assists were going up, but the actual transport rate was maybe going down, but it was still staying consistently high. And this was informative and really, sort of intuitive, acknowledging that we have an aging community out there that are living at home, but are having increased fall risks. And we're having to find a way to address that with our healthcare system. The other thing that this data helped them appreciate was of those who called for a fall-related call, 1/3 of them would soon call again, sometimes within just a number of hours between the first call and a second call, clearly indicating someone who would need ongoing help and support to prevent additional falls from occurring. So what we decided to do, kind of using a combination of our interests and expertise, my interest and background was in system science and complexity science, and tying that specifically to research approaches and ideally quality improvement initiatives. So Carmen had the context and I had the methodology to see if we could tackle this wicked problem together. What actually ended up happening was through a serendipitous encounter at a local arts festival, one of our research coordinators, who's been a very important part of our team, lived in the community of Upper Arlington and struck up a conversation with their fire EMS unit just about the fall lift assist problem that we were kind of interested in studying. And what she found out was on that very day, it was the start of what they called their UA Cares community paramedic program. In the state of Ohio, they had recently passed legislation that enabled paramedics to be able to go back into the homes of people who were at risk and perhaps not in emergency situations, but help address some of their regular health concerns. And so we began conversations with them to see if they had interest in partnering with us on kind of a research and implementation effort to address this wicked problem of falls in their community. We were very grateful that they said yes and had very similar interests and had fortunately just put the infrastructure together to directly allow us to work with them on building in fall prevention procedures and processes within their community paramedic program. One of our early efforts was to actually start a stakeholder collaborative where we invited people from all parts of different sectors of healthcare, not just restricted to Ohio State or that specific city. We had fire EMS partners from across the state of Ohio joining us. Prior to the pandemic, we were able to actually meet in person. We did lots of brainstorming. We did lots of information sharing, connecting resources, and we're still meeting on a regular basis on a quarterly kind of level today. And as a group, we wrote a charter, and we call it the Community-Centered Fall Intervention Team, with the idea of us working together in a sort of institutional and professionally agnostic way to help wrap our arms around people in the community who are at the greatest risk for falls. We started with Gemba walks, where we shared our sort of professional experiences, our places of work, our processes with each other by actually getting in the shoes and the clothes and walking the paths of each other's daily lives and caring for people with high risk for falls. And so we spent time at the fire station. Our fire EMS partners came and spent time at the hospital and our physical therapy clinic with us. I even put on the fire gear. I slid down the fire pole. The idea was to help get our sensibilities together about what we were each experiencing from navigating this problem. Our emphasis was on co-creation of a solution, and we engaged in mapping using systems science kind of approaches and methodologies, as well as series of trials of strategies to help improve our ability to kind of come up with solutions that would work in a sustainable way. So this is actually on the right as a photo of me engaging in some quality improvement training with the fire EMS partners that we are working with. Our goal was to help them be sustainable with whatever strategy we put in place, would make sure that they had the skills, the quality improvement skills to work moving forward, even after maybe our partnership became less, less frequent. And as they learned, they actually started to train each other in things like grab bar installation. And that's actually another picture of them having partnered with Lowe's, who donated some materials that allowed them to practice installing grab bars in common places like a bathroom tile surface. So again, just already kind of having mentioned the systems complexity science approach, we used a lot of those tools from my background in the systems thinking and modeling areas. And then we talked with them a lot about systems thinking approaches. So just to give a little background on what we were talking about with systems thinking approaches, when you engage in systems thinking, a lot of times the effort is really kind of going back and forth between kind of the local level and the macro level. So it's kind of like being in the forest and being able to see the forest through the trees and the trees through the forest, and kind of moving your way back and forth between the micro level everyday context that you're experiencing related to the problem, as well as the macro level problems and experiences that are happening at sort of the population or public health level. And we discussed that a lot with our community paramedic partners. One of the things that we talked about early on was envisioning this support system that is available to people, to older adults who may be at risk for falls, as being, this group of individual and siloed people, something like your friends or your healthcare providers, your physical therapists or rehab specialists, and your family may be all options that may be available for helping a person stay safe in their home. However, it's often very disconnected in that the healthcare providers don't necessarily know the friends don't necessarily know the family, and the family doesn't necessarily know, the rehab specialist. It can go on and on. So we're all maybe in support of helping the person, but we're not coordinating our efforts together. So we talked about what if our fire EMS units, who were local to the community and often knew their most vulnerable citizens because they were seeing them again and again for various healthcare calls, became a core and integral part of that network of people that were available to help this person? And could they help support the care coordination efforts to really make this a united effort toward helping that person live safely in their own home? We engaged in systems modeling approaches. We did process mapping. We did some social network analysis strategies. We used the socio-ecological model, all as ways to help us brainstorm and think about the exact problems we were facing and potential strategies to address their individual local level problems and the global health problems. We tied this specifically to a research approach in the space of implementation science. We used the EPIS framework, exploration, preparation, implementation, and sustainment framework. And we focused primarily at first on that exploration phase. So we were talking a lot about what is possible, engaging in the Gemba walks, literature searches, and sharing about what was already out there in terms of best practices, and looking at their internal data and their processes that they were currently using to address any sort of healthcare problem in the citizens in their community. We also talked to a variety of stakeholders through a qualitative study, and that included focus groups with multiple different stakeholder groups. So let me just share a couple of quotes here. So an older adult in the community said, I like the idea of somebody coming and saying, the way your furniture arranged is a fall risk. Would you instead do this? A caregiver for an older adult mentioned, people love the fire department and the medics. They're so caring and wonderful. I think they can help people really get over the hurdle of, I don't want to do this. My family is making me do this. A paramedic said, we go see them again. We don't have the information from the previous run, so we're starting fresh every single time. Another paramedic said, you think the systems sort of talk to each other, but not every file gets transferred over. I can also imagine it would be frustrating for patients while we are sharing. we aren't sharing everything. And in the context of fire and EMS units, a lot of times they're doing shift work. So shift A, B, and C may be seeing the same exact patient on each of those shifts. However, because they're not necessarily talking to one another, they're not really recognizing the fact that the same person has called repeatedly on several days. So unless they have their data and communication infrastructure well designed to capture that information and share that information across shifts, it's quite possible that some of these kind of problems can go on persistently for months and months without anybody realizing that it's the same person over and over again. So in the preparation phase, we did a lot of talking about what would be potential solutions, especially alongside their current operations. So the goal was to make sure whatever we picked as a solution was financially able to be sustained for them beyond our work with them, that it was going to work in parallel and ideally in a synergistic way with their current operations and practices, or that we were going to be able to shift their current operations and processes slightly toward a direction that would be better for all. The other thing we did in the preparation phase was that we worked with our community partners on securing funding sources. A lot of the things that we wanted to trial were outside their current operating budget. And we knew that we were going to be maybe trying to lead this on a state, if not national level scale eventually. And so we sought multiple different sources of funding. And collectively, this added up to a really nice funded set of resources we could use for our quality improvement types of initiatives, including philanthropic funds, a couple of small NIH grants, and several local institutional grants for various components of what we were going to be trialing. So some of these were development or planning grants, some of these were research grants, and some of them were just donor money. The donor money was particularly valuable because it really gave us the opportunity to try different things that research funding mechanisms might not normally fund. The model that we were operating from was to really think about using this community paramedic model as a way to systematically identify and systematically deliver targeted interventions to help with timely and specific fall prevention interventions among people who really needed it. In doing so, we hoped it would help reduce and eliminate the population of community members that were highly vulnerable to falls, and by decreasing their vulnerability, and that we were going to reduce and eliminate these individuals' barriers to care by helping to coordinate their provider, their clinic, health system, family, social networks. And ultimately, our goal was to improve patient fall risk and outcomes by putting interventions directly into their homes that were very personalized to their needs. So the third component of our approach here was really diving into the quality improvement strategies, or kind of an agile implementation approach. And with that, we were using a key driver diagram to really drive our efforts and track our efforts over time. So here's an example of our key driver diagram in progress. We had a SMART aim of reducing the number of fall-related 911 calls and fall-related transports by 20% by December 31st, 2019. Here's some of the key drivers, which were derived from literature searches, our stakeholder interviews, our Gemba walks, all the things that we knew we felt like we needed a target to successfully achieve our goal. We had some secondary key drivers to help us organize our thinking and processes. And then we have our list of targeted interventions on that far right side that included, things like offering community paramedic workshops, and best practice benchmarking. We do peer mentoring and train the trainer types of modeling. We have ongoing stakeholder input and feedback. We made sure that we created processes for directly sharing information between the community paramedic program and their 911 call system. So more than I can share in detail today, we have published some of these results in multiple forums. And so this is just the high level view methodologically of what we did from the implementation standpoint. So engaging in our different strategies, once we had a plan, we used the model for improvement to use plan to study act cycles to trial and optimize our different strategies in a way that they could sustain it in their operations and from a funding perspective. The sustainment piece was really critical. After we had the infrastructure in place, that we were able to follow them all the way through the pandemic, and our strategies continue to hold up even in the midst of the healthcare system sort of falling apart all around them, and that they had to lower their emphasis on the fall prevention, but they still had great success implementing the strategies that we had come up together with them. So on the left-hand side here, this represents sort of the process map that we worked with them to develop for their intake and intervention planning processes. We helped develop their systematic tracking forms and eventually help them plan for transitions of care should they need to happen. We helped them develop a pay it forward campaign, which they were able to offer the services like grab bar installations, home evaluations, care coordination, follow-up at no cost to their community members. And that largely came from the donations that we received in the philanthropic, and funding to trial our solutions. And then they were able to have the data to share with their city to show how important it was about what they were offering. And the city was able to dedicate budget to continue the efforts moving forward. And additionally, they set up a pay it forward campaign where some of the citizens that were benefiting from the fall prevention interventions we were putting into place could then donate to pay it forward to someone else in their community. And just a high level sharing of the results here. So we were able to reduce the number of fall calls by over 60% that they were receiving on a monthly basis. We were also able to work with them to reduce the percentage of fall-related calls that was resulting in transport because they were able to offer follow-up fall prevention services instead of just taking somebody who was vulnerable to a fall to the hospital in hopes that somebody would help get them the care that they needed. They were actually able to get in some proactive care coordination, fall prevention strategies into the home, and that resulted in a significant drop in the number of calls resulting in hospital transports. Some key learnings I'd like to share. One of the biggest things is that we had supportive EMS leaders, staff, and community. From the start, we had the chief of the fire division, involved in some of the planning and then communicating that to their city council and other places to ensure that they were updated on how the money and the resources were being used. We were able to use single sort of targeted efforts to find cases of people who were the most vulnerable in the community. So who were those frequent callers and get solutions into their home. So this graph actually represents a single community member who was calling on an average of about 2 to 3 times per month prior to implementing the community fit efforts. And then by the time we actually reached all the way through the pandemic and into 2021, that individual was pretty much down to 0 calls per month. A big learning that we learned is that, the fall calls, the frequent fall callers were not just older individuals. A lot of them were community members in the area with high comorbidities, disabilities, and other healthcare struggles. So we loosened our inclusion criteria for who was eligible for our efforts from an age restriction to widely, and it was just targeting the frequent callers who then were identified as high risk. Another key learning was that we had to work hard to connect the information sources. We needed to create information systems that would adequately track information about the patients and then feed it back to the 911 scenes. And then information from the 911 scenes back to the paramedic team and other resources. Their data tracking was actually occurring in 2 different systems that didn't speak to each other. And so we were able to create an infrastructure to support basically like an easy button. So when they had somebody that they were on a 911 call for that seemed like they could benefit from follow-up efforts, they basically clicked the button in their electronic health record, and that would shoot a communication email to the community paramedic team to then follow up on that individual. Some other key learnings was that, we really had to embrace creativity, adaptive solutions, and push new boundaries. We engaged in industry partnerships. Lowe's became a big part of our team. Flexible thinking, working toward new standards, better processes, and sustainable improvements in outcomes. One of our biggest learnings was, initially we couldn't put in grab bars, and we were looking at different handy services to help us, communicate resources for grab bar installation, and realizing that was going to be too difficult of a channel. Our firefighter friends said, many of us install fire alarms on a regular basis as part of our daily jobs. Can we train ourselves to install grab bars and get the legal approval to do it? And so they actually came up with that solution on their own, and we're very excited. And they continue to have that as something that their different staff members engage in on a regular basis. It's part of their daily operations is installing grab bars in the community. And another big learning was, the key was really getting this safety net in place by putting the community paramedic as part of the care coordination team. They knew the neighbors, they knew the resources in their community. They were able to connect the dots. They were able to get the permission from the patients to support communications with healthcare providers, get them scheduled for follow-up appointments with their primary care physicians, help let their family members know when they were struggling, help get them Alexas and different types of technology into their home so that they could, call for help if they needed to, get lock boxes on their houses and things of that nature. So it was really kind of connecting the dots between those different silos that was a key learning for us. And the final key learning that I'll share is, in this process of working so hard with our community partners, we really had life-changing relationships that we built throughout the process. We know that it's a struggle for everybody who may be suffering from any type of injury or healthcare condition that makes them frail or have to use their body in different ways. And, it doesn't really matter where in the lifespan that they are. Just getting up 3 flights of stairs into their home after a hospital stay can be extremely difficult. So what I want to share is kind of going back to my dad's story. Once we learned of his diagnosis, we were able to leverage our fire EMS partners to help get the grab bars installed in his home so he could get out of the hospital sooner and was actually able to work more at home on inpatient instead of having to go to an inpatient rehab services. He was fortunate he had a physical therapist and an orthopedic surgeon for his kids who were able to help him. And so we were able to really get a nice transition home in place for him. And our vision moving forward is seeing how we can make this something that is possible for anybody who wants and needs it. So let me share his perspective on this, his reflection on being able to engage with the community paramedics.
When I was able to get out of the hospital, this condo had to be handicap accessible. They came in and one day they put it all together so I could get home and get out of the hospital. I was so grateful for that because I could rehab here. I didn't have to go anywhere else. And they were just wonderful. And I just think the paramedics and Katie's husband, Eric. And they put it everywhere I needed it so I could go to the bathroom, so I could take a shower, so I could be safe and I could be here, not have to be in the hospital anymore.
So moving forward, the Community-Centered Fall Intervention team, this approach is something that we're trying to share. On a systems level, if you think about conventional fall risk identification and fall prevention programs, they're typically working at that individual sort of micro level. Maybe they're offering it to the community, but they're still expecting individuals to kind of find and get connected to the program on their own. Our efforts with EMS agencies really took that to the community level, where the community became a resource for identifying the people in their community who are at the greatest risk and connecting them with the resources that they could use, which gets us even higher up that sort of micro meso macro scale for hopefully a more direct impact on changing the population health outcomes related to falls. So thank you for listening to the presentation. I have way too many mentors, faculty, students, clinicians, staff, collaborators, community partners, and funders who have made this possible more than I can acknowledge in any one slide. Here's an example of some of our funding sources. And please check out the resources page for our publications where we're able to more readily share our acknowledgements of the people who have been involved in our work so far.